Hi guys, I promise this is the last video for CS2. So for this video, I just want to summarize the main points for the BLS and the first aid stuff that we've discussed over the last few videos. So in the exam actually, so for the final exam for CS2, basically we're going to get given a BLS scenario. So we need to do CPR for 2 minutes. So that's 5 cycles for an adult. And then we're going to get given another BLS scenario or a first aid scenario. Or we're going to get given an ECG problem that we need to interpret. And we need to explain how to place ECGs and, be able to show the examiner that we know where to place the ECGs and how to interpret them. So I've done that in a completely separate video. So today, I just want to summarize the main points for BLS and for some of the first aid scenarios that we might encounter for the exam. So let's start with the BLS sequence for one rescuer for an adult victim. So the first thing that we need to do is we need to verify that the scene is safe. Make sure that the scene is safe for us and for the victim, so we don't become a victim ourselves. The second step is to check for responsiveness. So we do this by doing tactile and verbal stimulation. So we tap the patient on the chest or shake them and say, hey, are you okay? We check for pulse and we check for breathing. For pulse, we check the carotid pulse for an adult, and breathing, we just look if their chest is rising, or we can hear if there are any breath sounds, and we can feel as well the movement of air from their nose or from their mouth. If there's no response, we call for help or we activate the emergency response system. So there's 3 scenarios. Moving on from this, so we can have a victim who is breathing and with a pulse. So in this case, we just stay with the victim until the emergency medical services arrive. We check their pulse every 2 minutes just to make sure that there's no change in their vitals and that they're still stable. And then if there is pulse but there's no breathing, what we need to do is we just need to give rescue breaths at the rate of 1 breath per 5 to 6 seconds. So that's 10 to 12 breaths per minute. And then if the third case is the worst case, so if there's no pulse and there's no breathing, we need to immediately start with our compressions. So we do 30 compressions, and then after 30 compressions, we check the airway. So if there's an obstruction there, we need to remove it using that hooking technique. If we can't see any obstruction, then we can give 2 rescue breaths. Even if we see an obstruction, we can still give 2 rescue breaths just to determine if that obstruction is a complete obstruction or partial obstruction. But anyway, we do compressions and then we check the airway. If there's an obstruction, we remove the obstruction if we can. If we see the obstruction but we can't remove it, then don't perform a blind finger sweep. Don't just try take it out, because you're just gonna risk pushing it further back into the airway. So if you can see the obstruction but it's so far, so deep down, just return with compressions. So you do this cycle, so 30 compressions to 2 rescue breaths until the emergency medical services arrive, or until you get someone to bring you an AED machine. For the adult CPR with 2 rescuers, what we need to do is we need to allocate roles. So one person could be in charge of the chest compressions, and so that person would position themselves at the side of the victim, and the other person can position themselves at the head side of the victim and be in charge with the breathing and the ventilation, the airways basically. So rescuer 1, who's in charge of the chest compressions, should give chest compressions at the rate of 100 to 120 per minute, depth of 1/3 of the AP diameter. And that rescuer needs to count out loud, so rescuer 2 can anticipate when the switch is gonna happen and when to give rescue breaths. So rescuer 2 on the head side needs to do the head tilt chin lift method and give 2 rescue breaths with the ambu bag. Or if we suspect any head, neck, or spinal trauma to this victim, rescuer 2 can do the jaw thrust method, and rescuer 1 after compressions can squeeze the ambu bag and give 2 rescue breaths, looking for that rise in the chest to make sure that the breaths are effective. For the adult CPR with 2 rescuers, the compression to ventilation ratio is still 30:2. Also, the rescuers, they need to switch after 2 minutes or 5 cycles of compressions because it can get tiring. So they just switch positions. So rescuer 1 would now do the airway and ventilation, and rescuer 2 would now do the compressions. Moving on to the child BLS sequence for 1 rescuer. So if you only have 1 rescuer and the victim is a child, so we first need to check and verify that the scene is safe, move the victim if it's not safe, and then we need to check for responsiveness by doing the tactile and verbal stimulation, check the pulse, check the breathing. If there's no response, we call the emergency medical services. And then again, there's 3 different scenarios. So if the patient has a pulse and is breathing, then we just stay with the victim until the emergency response system arrive. If the patient has a pulse but is not breathing, because this is a child, the rate would be different. So it would be 1 rescue breath per 3 to 5 seconds, which means that we're giving 12 to 20 breaths in total per minute. If the patient has no pulse, no breathing, we start with compression. So we give 30 compressions. 30 chest compressions, and then we check the airway. And if there's an obstruction, we try to remove the obstruction if we can. If there isn't, then we don't need to check airway for the second cycle. And we give 2 rescue breaths. So if there's just 1 single rescuer, the compression to ventilation ratio is 30:2. So you do 5 cycles of that, and then you recheck the pulse. And you keep doing this until like the emergency medical services arrive or an AED becomes available to you. So the BLS sequence for a child with 2 rescuers, the first few steps are the same. Verify that the scene is safe, and then you need to check for responsiveness. So tactile stimulus, verbal stimulus, check for pulse, check for breathing. No response, you call for the emergency medical services. And let's just move on if there's no pulse, no breathing. Okay, so if there's no pulse and no breathing, what you do is you give 15 chest compressions to 2 rescue breaths because there's 2 rescuers. The ratio of compressions to rescue breaths are going to be 15:2. This means that the cycle would be shorter. So within 2 minutes, you would have done 8 cycles of compressions and ventilation. So the switch between the 2 rescuers would be after 8 cycles, around about 8 cycles. It would still be after 2 minutes, but it would be after 8 cycles instead of 5 in comparison to the adult one. For infants with 1 rescuer, again, we need to verify the scene. We need to check for responsiveness, tactile and verbal stimulation. But since this is an infant, we can't just shake the baby. What we do is we rub the chest or rub the feet. That's the tactile stimulation. And we also need to say something for verbal stimulation. We can still say, hey, are you okay? Perfectly fine. We check for the pulse and we check for the breathing. So pulse in a baby is checked on like the femoral artery, or you could use brachial as well, but not carotid. Okay, so femoral or brachial. Again, if there's no response from the baby, we need to call the emergency response system and call for help. And then again, there's 3 different situations. So if the baby is breathing and has a pulse, we stay with the baby till the emergency medical services arrive. If the baby has a pulse but is not breathing, we need to give rescue breaths. So 1 rescue breath per 3 to 5 seconds, in total of 12 to 20 breaths per minute. And if the baby is not breathing and has no pulse, we need to give chest compression. So we could use the 2-finger technique. So we find the nipple line of the baby, place 2 fingers below the nipple line, like in the middle. Or we could do the 2-thumb encircling technique. So we encircle the baby's chest with our thumb. So the thumb has to go like on the same spot where the 2 fingers would go in the 2-finger technique. And since we're talking about 1 single rescuer, the compressions to ventilation ratio would be 30:2. Also, just a tip for the exam or in real life, I know that you could approach the baby in any direction because the baby is small, and you could give chest compressions in any any directions or any place, but it's easier to place yourself at the head side of the baby because it's going to be easier for you to do the compressions and the rescue breaths, especially if you're alone, if you position yourself at the head side of the infant. So the BLS sequence for an infant with 2 rescuers, it's similar to the one that I just previously discussed, but the compression to ventilation ratio would change. So it would be 15 compressions to 2 rescue breaths. This means as well that the change would be after around 8 cycles. It would still be after 2 minutes, but after 8 cycles of compressions and ventilations instead of after 5 cycles. So if we have an AED device, we can use this and we should use this. So the steps would still be identical as the ones that I've just previously described. So for adults and children, so when we get the AED machine, the first step always is to power it on, to turn the AED machine on. And then once that's on, we place the pads accordingly. So it depends on the instructions on the AED device and the size of the chest of the victim. So if the victim is a small child, it might be easier to do the anterior-posterior placement so that the pads won't overlap. You could still do the anterolateral placement, but just make sure that the pads don't touch each other or don't overlap, okay? And once you've attached the pads, what you need to do is to follow the AED prompts. So it would analyze the rhythm. It would tell you to stay clear, analyzing rhythm, and it would advise you to give a shock if it's a shockable rhythm. It would say shock advised, and then you just give the shock and then carry on with the compressions after that. Or it would say no shock needed or no shock advised, and then you just carry on with the compressions after that. And then you will just keep doing this. Also, you check the airway as well. So after giving the shock or no shock, you do compressions. You check the airway on the first cycle. And if that's clear, you don't need to check it for the next cycle. If there's an obstruction that you can see, take it out before you give 2 rescue breaths. You only need to keep checking the airway if there's gonna be an obstruction that you can't remove, or if, for example, the patient is bleeding in their tongue and they might aspirate with the blood, so you need to constantly clear that blood. So in that case, you would need to check the airway with every cycle. But otherwise, you just check the airways during the first cycle, okay? So again, AED, it would tell you to analyze the rhythm. It would give you instructions, advise you to give a shock or no shock. And then after that, you carry on with your compressions. You check the airway in the first cycle. And then you do your chest compressions again, then rescue breaths. Then that's 5 cycles. And the AED would prompt you for another rhythm check. And then it just carries on and on and on until the emergency medical services arrive or there's a change in the victim, or if the victim regains consciousness, for example. In infants, we don't use the AED machine actually. We use a manual defibrillator. And this is because the AED machine can't really reduce the dose so much for a child unless it's fitted with an attenuator, or there's an opportunity for you to pre-program the AED machine suitable to give pediatric doses. But otherwise, you don't use this in the exam anyway. You don't use the AED machine for an infant. So what you have to say to the examiner is that we don't use an AED device for an infant. What we do is we use a manual defibrillator. So I'm gonna sit here and carry on with the compressions and my rescue breaths until more advanced medical services arrive who can use a manual defibrillator for this infant. So the next topic in our BLS course is choking. So for a conscious adult with mild choking, we just need to encourage the adult to keep coughing, keep trying to relieve the obstruction by themselves. So signs of mild choking include red face, and obviously there's sounds of coughing. You could hear that, and there's good air exchange. This mild obstruction can then turn into a severe obstruction. So signs of severe airway obstruction in an adult include the clutching of the neck, You won't hear any coughing sounds. The person would try to cough, but there would be no audible sounds because it's completely obstructed. The airways are completely obstructed. Also, the face of the patient or the skin color wouldn't be red. It would be pale or even cyanotic. So what you do in this case, if a conscious adult has severe choking, is you perform the Heimlich maneuver or the abdominal thrusts. So what you do is you stand behind the patient or the victim, you wrap your arms around their abdomen and you make a fist. And the thumb side of your fist goes above the umbilicus but below the xiphoid process. And you just wrap it, you just secure it with this hand like this. And you give forceful upward abdominal thrusts. So you do that until the object is expelled out or until the patient becomes unconscious. So if our adult victim falls unconscious, we don't check the pulse. This is the only scenario where we do not check the pulse when someone falls unresponsive, because in this case, we're going to give chest compressions, not for circulation. We're going to give chest compressions as sort of like a substitute or as an alternative to abdominal thrusts. So what we do is when the patient falls unconscious after, choking, and we need to give 30 chest compressions, and then we need to check for the airway. If we can see the obstruction, we remove it using a hooking technique. We don't perform any blind finger sweeps, and then we can still give 2 rescue breaths. So if the chest doesn't rise at all, then that suggests that it's a complete or full obstruction of the airway. If it rises a little bit, then it's a better scenario. It means that it's only a partial obstruction. So we carry on doing chest compressions, so 30 chest compressions, and then we check the airways again. We give 2 rescue breaths. So we keep repeating this until we remove the obstruction successfully or until the patient regains consciousness. It's important for us to encourage that person to get seen by a healthcare provider or wait for the emergency medical services to review the patient. Just to check if there are any injuries from the abdominal thrusts or the chest compressions. For a conscious severe choking baby, the signs would be the baby would be in panic, so the baby would move a lot, but you won't hear any audible noises, so you won't hear the baby cry, although the baby would try to cry. No coughing, no crying, no sound at all, and maybe no air exchange. So if the baby's conscious and severely choking, what we need to do is we need to give the baby 5 back slaps followed by 5 chest thrusts using our 2 fingers. So what we do is we give back slaps and we keep giving the chest thrust until the object is expelled out of the baby's airway. Or until we hear the baby cry, because that suggests that the object has been removed or expelled out. Similar to adults, when a severe choking baby falls unconscious, we don't check the pulse. We just start with the compressions straight away, because we're doing the compressions not for the sake of reviving the circulation, but for the sake of giving enough force to thrust to help expel that object out of the baby's airways. The next one is anaphylaxis or severe allergic reaction. So signs include swelling of the face, hands, feet, and tongue, shortness of breath, even signs of shock like low blood pressure. We need to ask the victim if they have an EpiPen, and if they do, then we hand it to them and then ask them to use it if they know how to. If they don't know how to use an EpiPen, then we could help the patient. So what we need to do is imagine this is the EpiPen. We need to remove the safety cap, and then we need to position the needle. So the safety cap is usually blue in color, but you can check because it depends on the different injectors that you get. So usually it's the blue cap. So you remove the safety cap, the blue cap, and then you position the red I think it's orange, the orange needle end against the patient's thigh between the hip and the knee, like midway between the hip and the knee, and you press until you press for 10 seconds until all the medication has been delivered to the patient's system. And the book says you can massage for 10 seconds, but the instructor said it's not necessary to do that. You need to, however, dispose the EpiPen safely and appropriately, because again, it's a sharp and it's a medication. So if you don't know where to dispose this, just give it to the emergency medical services when they arrive. The next scenario can be severe bleeding. So for any bleeding, regardless of the severity, like mild or severe, we first apply direct pressure to the wound. So we apply direct pressure and dressing on top of the wound. And if that doesn't work, we apply more pressure and more dressing. And if that doesn't work still, we can use a tourniquet. So we can find a tourniquet in the first aid kit, or if there's no first aid kit where you are, you can just make one yourself. So you apply the tourniquet like 4 centimeters above the injury site, and you would just wrap it around, and then you tighten it with the stick until the bleeding stops. So this is gonna be painful for the victim. Just remind the victim that it's gonna be painful, but it's gonna stop the bleeding, and the pain is only gonna last a few seconds or minutes, and then the limb would feel numb after that. You need to note down the time that you've applied the tourniquet, and you need to call the emergency medical services if you apply tourniquet. And this is because applying the tourniquet can actually cause the necrosis of the tissue. So it's important to get advanced help and note the time that you've started the tourniquet, that you've put it on the patient. The tourniquet can only be put on for a maximum of 2 hours. And if help is still not there after 2 hours, what you can do is to remove the tourniquet and just apply direct pressure onto the wound if it's still bleeding for a few minutes, and then you can reapply the tourniquet for another 2 hours, and then you just keep doing that until you get more advanced help come your way. Another emergency scenario that you might face in the exam is seizures. So seizures are just abnormal electrical activities in the brain, and this is caused by many different things. So it can be commonly caused by a medical condition called epilepsy. It can also be caused by hypoglycemia or heat stroke. So if you see someone having a seizure, you need to make sure that the scene is safe for the victim. So you move any objects or any hazards around that might harm the victim. And you protect their head by placing a soft object under their head, like a towel or any pillows if there are any around. And then after that, you need to note down the time that you've observed the seizure happen and the time when it finished. So the start and the start when the seizure happens, and then when it ended. Usually this only lasts for a couple of seconds. And this is important information that you can then relay to the emergency medical services when they arrive. So after the person has a seizure, what you need to do is you need to check for injuries. You need to check the tongue, because more often than not, it would be injured because they would have bitten their tongue, and they can aspirate from the blood. Or if there's any like teeth injuries, then a tooth might be a choking hazard, and you need to deal with that. So you need to check that. You need to check for injuries in the head as well if that's bleeding, and you address any external bleeding that you can fix, and the rest you leave for the medical emergency services when they arrive. So once the patient has a seizure, you check for the injuries and you place them in a side lying position if you can. Obviously, if you suspect any head or neck injuries, then you don't move the victim, but it's unlikely in this case. So head, neck, and spine injuries are only likely if they fall from a very high distance greater than their height, or if they've been involved in a car crash accident or a sporting injury where they get hit so hard in the spine area, the neck area, or the head area. But after a seizure, this is quite unlikely. So you need to place them in a side-lying position after their seizure episode. And you need to check their pulse and their breathing after they've had the seizure. Another scenario may be fainting. So fainting is the transient loss of consciousness followed by a recovery. So this can be due to many different reasons, like a very severe heart arrhythmia, for example, or just the fact that they're dehydrated, they haven't eaten or drank enough, and especially when it's hot weather and they stand up quickly. Or a person may faint upon hearing something that provokes surprise or fear, or seeing things that provoke surprise or fear. Like if they see something that they're afraid of, like a snake or a spider or blood, or they hear a bad news, for example. If you're about to see someone faint, what you can do is to help them lay down on the floor in a controlled manner so they don't hit their head or accumulate any other injuries. If you find them on the floor already, what you need to do is to check their pulse and check their breathing, and activate emergency medical services, because you never know what the cause of fainting is. This might be due to a very bad, very severe heart arrhythmia, and you need to call for help. So in any case, you need to call for help. And then so once you find them on the floor, you've checked the pulse, you've checked the breathing, you carry on with your normal BLS algorithm. If they have a pulse and they're breathing, you can position them in a shock position. So you lie them on the floor, but their legs are elevated. And you can cover them with a blanket to keep them warm. And what this does, the elevation of the legs, it forces more blood to come back to the circulation into the brain, which might be the cause of their syncope, reduced blood flow to the brain. So it just increases blood flow back to the brain, basically. The next skill that we need to be able to demonstrate is lateral uterine displacement. So this we do for a pregnant lady who is lying supine, and we can't put her in a side lying position for whatever reason, like if we suspect any spinal injury, any neck injury, any head trauma. If you find the lady after a car accident, for example, or if the lady fell from a great height, then we suspect head, neck, and spine injuries. So instead of putting the pregnant lady in a side lying position, we can do a lateral uterine displacement instead. So we do this by, there's two ways. We can either position ourselves on the right side of the patient, and we can push, left side. Yeah, so you're on the right side, so this side of the patient, and you push the uterus to the left side. Or you can position yourself on the left side of the patient and use both arms to pull the uterus towards the left side. So the second method, it's actually it's easier because you're going to be able to do this for a long time, and the pushing method is much more exhausting, but this might be the only option if there's only one rescuer. If there are any bystanders around and you need to do CPR, you can instruct that person to position themselves on the left side and displace the uterus using the two-arm method by pulling the uterus towards them. In that way, you can perform CPR on the pregnant lady. The reason for lateral uterine displacement is to relieve the pressure off from the inferior vena cava, because the uterus and the baby is compressing on the inferior vena cava, and therefore this reduces cardiac output and venous return. So if we displace the uterus to the left side, we alleviate some of that compression, some of that pressure, and we allow more blood flow, so increase venous return to the heart. We may also be presented with like injuries relating to the cold weather, so hypothermia and frostbites. So what we do if we suspect that someone has hypothermia is we verify the scene, check for responsiveness, and then if there's any wet clothing, we remove that, we dry the patient, and then we put fresh dry clothes on them. We cover them with a blanket or anything just to insulate them. Even newspapers will do. And then we just stay with them as we wait for the emergency medical response services to arrive and act accordingly depending on if there's pulse or if there isn't pulse. Just remember our normal BLS algorithm. And for frostbites, what you need to do is you need to avoid rubbing that area, or do not thaw that area, because it would just increase damage. It would just cause more damage. So you need to remove any tight clothing or tight jewelry around that frostbitten area, and you can cover it with like clothes, dry clothes, just to keep the area warm. But you do not rub it, you do not thaw the area, you leave it alone. So for heat-related injuries, on the other hand, like dehydration, heat cramps or heat exhaustion, what we need to do is we need to make sure, or we need to encourage the victim to cool off, to basically stop whatever they're doing. If they're like running running under the sunlight, for God knows how long, we need to tell them to stop and to cool off. We need to like spray them with cool water if we have a cool water spray. If we don't, we can like submerge some towels or clothing in cool or cold water, and just put this on the patient's head, neck, armpit, or groin to help them cool off. And we can give them some drink. So water would be okay, but even better would be like any fluids with electrolytes or sugar, like a sports drink, just to replenish the electrolytes and the fluids that they've lost. If this is a more severe heat-related injury, for instance, a heat stroke, what we need to do is we need to call the emergency medical services, because this is serious. And we need to submerge the victim in cool water, preferably the whole body. If not, then maybe just up to the neck area, to help them cool off. And again, we act accordingly. If there's pulse, if there's breathing, we use the BLS knowledge that we have. For head, neck, and spine injuries, I've already discussed this earlier. So we can suspect these types of injuries if someone falls from a great height, or is involved in a car crash, either inside the car or has been hit by a car, motorbike accident. Sporting injuries if they get hit by someone, or they hit something, or they get hit by a ball or an object that's traveling at a great speed and at a great force, then we can suspect these sort of injuries. And what we need to do is we need to verify that the scene is safe, check for responsiveness, and all of that. And if the patient or if the victim if you find them facing down after a car accident, for example, you can still check their responsiveness in that position. You don't move them because they might have head, neck, spine injury. You only move them if they qualify in any of these three categories. So if you need to give CPR, so if you need to turn them around and you need to give them CPR because they don't have a pulse and they're not breathing. The second is if you need to move them away from danger, then you can turn them around. The third one is if this position is compromising their airway, then you can move them and you can turn them around. We can also be presented with poison emergencies. So if we suspect that someone has ingested, inhaled, or has been in contact with some poison or poisonous substances, we need to immediately call the poison control center, and they would guide us. They would help us to best help the victim, because they're gonna ask certain things like what the poison is, can you describe the poison if you don't know the name, how old the victim is, how much of the poison was ingested, when the poison was ingested, how the victim is doing now, etc., etc. So they would tell us exactly how we can deal best with this specific poison and this specific situation. We just need to help them, for example, get some poisonous powder off their skin. We can use gloved hands when we're brushing off that poisonous powder off someone's skin. Or if they got it in their eye, we can escort them safely to an eye wash station, and so they could wash their eye under lots of running water. You need to make sure that the affected eye goes lower in the tap, so you don't rinse it off. So you don't rinse off the chemicals or the poison into the healthy eye. And finally, we can be presented with electrical injuries. So the important thing is that you need to verify that the scene is safe. You need to make sure that that before you approach the victim is disconnected from the power source, because electricity can travel from that victim, from the power source to the victim and then to you. So before you check for pulse and breathing, before you just touch the victim, make sure that they're disconnected from the power source. If they're not, then you can turn off the power source if it's safe and if you're trained to do so. If it's unsafe, then just call the emergency medical services. But if it's safe, if the person is disconnected from the power source, you can approach the person, check for pulse, check for breathing, and then continue with the normal BLS algorithm.